Hello, everyone, and welcome. Thank you for joining today's webinar, A Year in Review, America's Fight Against COVID-19. I'm Sarah Dash, President and CEO of the Alliance for Health Policy, and I can tell you that a year ago, I never thought I would be doing dozens of webinars from my bedroom, living room, and neither did any of the rest of us, and yet here we are. For those who are not familiar with the Alliance, welcome. We're a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. And we gratefully acknowledge the National Institute for Healthcare Management Foundation for supporting today's important event. You can join our conversation on Twitter at All Health Live and our community at All Health Policy as well on Facebook and LinkedIn. A couple quick housekeeping notes to ask your questions. Please use the speech bubble icon in the right-hand side of your console. You can submit questions anytime. We'll address them during the broadcast, and you can chat any technical issues you might be experiencing. Also, check out our website, allhealthpolicy.org, to find background materials for today's briefing and a recording of today's webinar, which will be made available. So to say that this has been a momentous year would be an understatement. It's a really somber anniversary as we've lost over 529,000 of our fellow Americans, which is more than one for every minute in the last year. And it's also an opportunity for hope as we look towards the future, as vaccines begin to come online and as our friends and colleagues and neighbors begin to get vaccinated. And there are other causes for somber reflection and for hopeful looking towards the future. And that's what we're going to do today. One other note that I want to make is we've seen in a time when our country was already divided, unprecedented division politically over the course of this pandemic. And as a bipartisan organization, the Alliance hopes for opportunities for future bipartisan collaboration. And I think personally, that's something we can all agree on is that we want our economy to be strong and resilient, and we want our people to be strong and healthy and resilient. And so today, to help us talk through the implications of this last year of this pandemic are some phenomenal panelists, and they are going to be led in conversation by the incomparable Julie Rovner. Julie Rovner is the Chief Washington Correspondent for Kaiser Health News, the host of Kaiser Health News What the Health podcast. She joined KHN after 16 years as a health policy correspondent for NPR, where she helped to lead the network's coverage of the passage and implementation of the Affordable Care Act. In 2005, she was awarded the National Press Foundation's Everett McKinley Dirksen Award for Distinguished Reporting of Congress, and really she needs no introduction. Julie, thank you so much for joining us today and for introducing our distinguished panelists. Thank you all for joining us today for a day of reflection, and to our audience. Thank you, and I'm going to sign off and turn it over to you.
Thank you so much, Sarah. That was great. Welcome, everyone. Today we're going to reflect on the past year and discuss how the COVID-19 pandemic has shaped and will inform going forward clinical care, state preparedness, and the individual consumer experience. Today, I am honored to be joined by an esteemed group of experts to have this conversation. First, we have Frederick Isasi. He's Executive Director of Families USA, a leading national nonpartisan voice for healthcare consumers. Before coming to Families, Mr. Isasi worked at the National Governors Association and the Advisory Board Company. He's an expert on Medicaid, state innovation, health system transformation, behavioral health, and social determinants of health, as well as healthcare quality, payment, and equity issues. Frederick, thanks for joining us. Next, we have Dr. George Diaz. He's the Medical Director and Section Chief of Infectious Diseases at Providence Regional Medical Center in Everett in Washington State. Dr. Diaz successfully treated the first confirmed COVID-19 patient hospitalized on U.S. soil and pioneered a first-in-the-world use of remdesivir to prevent respiratory failure in COVID-19 patients. Dr. Diaz, thank you for joining us. And last, not least, we have Adrienne Castellotti. She is Chief of Government and Public Affairs at the National Association of County and City Health Officials, where she leads the association's efforts on policy development, communication, and federal advocacy. She previously worked at the Food and Drug Administration, where she led the agency's work with Congress on a wide range of policy topics and high-profile issues spent 7 years on Capitol Hill serving as Deputy Chief of Staff, Legislative Director, and Health Policy Advisor for a senior member of the House Energy and Commerce Committee. Adrian, thanks for being here. We have a lot to cover and not much time to cover it, so we're going to dive straight into questions and answers to maximize the hour. Remember, you can use the questions panel of the audience interface to submit your questions at any time. I'll try to get to as many as I can. I'm going to start with an opening question to each of the panelists. Frederick, let's begin with you. The last year has provided an opportunity to reflect on how interconnected our health system actually is with other aspects of our daily lives. How have individual and family attitudes changed towards how people seek care and who they trust for health communications? I understand Families USA has conducted some polling on this.
We sure have. Yeah, thank you so much for the question. And it's a joy to be here. We're big fans of the Alliance. We think it's really important work. It's so critical that we can engage in bipartisan communications and knowledge learning to move the country forward. So it's a joy to be here. We're big fans. So what we know is that we've gone through a really profound experience as a community, as a country. And, you know, it doesn't matter your wealth, your geography, your race, your gender, this has been a shared experience, and frankly, not just in the United States, but across the world. And one of the things that's happened, we went into the field about a month ago to really understand what has happened to the American understanding consciousness around health and healthcare. And we discovered a few things. Probably to your question, Julie, the most profound thing we discovered was a deeper and more a deeper understanding and commitment to the notion of the social determinants of health. That people can see the ways in which the extrinsic factors in your life, not just the physician that you might see or the clinic that you might go to for your primary care, but all the other factors, things like the job that you have, the environment in which you live, your access to things like clean air and your proclivity towards asthma, a lot of really profound, more public health and social determinant oriented issues have risen to the consciousness of the American people and a lot of policymakers around the country.
George, you've been at the forefront of COVID-19 treatment in the U.S. What can you tell us about the communication infrastructure and partnerships necessary for safe and efficient COVID response? And can you speak to how the pandemic is reshaping clinical practice?
Yeah, it has reshaped clinical practice quite a bit. The greatest, I think, change that occurred in clinical practice with respect to COVID, but is applicable to really any disease state, is the use of telehealth. When we were first seeing our surge of patients in February, we had done a lot of work in the weeks before that to stand up the infrastructure to be able to manage the disease in the outpatient setting. We wanted to be able to identify patients who were safe for home, but that we could also keep track of them safely at home and then bring them back to the hospital when they got sick. And we needed to be able to move patients who were COVID positive from the ED setting to the home setting in a safe way, thereby reducing our use of PPE, by being able to have a safe place for patients to wait for their results. Early in the pandemic, we had serious delays in testing results. And by employing telehealth and scaling it across our enterprise, and we have 50 hospitals on the West Coast, we were able to move thousands of patients, from the ED to home and keep them home safely, and then identify those patients who were at highest risk for decompensation and get them back into the hospital at the right time. And we know the system works. And so telehealth has allowed us really to, at least in the state that I work in, preserve the hospital beds and resources that are so critically needed, and allow us to manage the high volumes that we had early in the pandemic. We know that this use of telehealth has been beneficial, and the rules around telehealth were relaxed, I think, by the federal government, and allowed us to provide that service to our patients. We also know that within our telehealth system, we were able to address inequities in our population. We had translating services available for people that were non-English speaking. and those patients were equally as engaged as the rest of the population with our telehealth program. So we know addressing communities that have inequalities can be addressed through telehealth. And so that's, I think, been really a game changer for the way that we manage COVID. We also know that these services aren't uniformly applied everywhere. And even within our county, there are patients outside of our health system that provide care within community health clinics or other minority clinic systems that don't have access to this. And what we see is in those patients, delay of care and non-engagement with care and more likelihood of having test results take much longer. And so the morbidity is much higher in those populations, even locally, where we have a footprint, that they have worse outcomes. So while we're able to design these systems to improve the outcomes, they are limited to our health system and they're not uniform across the country or even within my county. I think that has really been the biggest game changer for the management of patients, and it really should continue. It's very difficult to build brick and mortar buildings for healthcare, and the more we can move it outside of those settings safely, the better our healthcare system will be.
I definitely want to circle back to telehealth, but first, Adrian, what are some of the opportunities and challenges in the interaction between states and localities in a public health emergency? Now that President Biden has signed the American Rescue Plan, how can we leverage COVID response dollars, and there are a lot of them coming, to build and maintain sustainable systems of care?
Just a small question. So we have our public health system really is a partnership across the federal government, state public health, and local health departments. And really that partnership, if it is not resourced and coordinated and communicating up and down the chain and back again, that's where we have challenges. And so throughout the entire pandemic, and I have a cat who's clearly coming to join us, we have had to work together across that. That has meant that, when we're all together and on message and working together, things can be good. There can also be challenges. Everyone's moving at 100 miles an hour. The local health departments that I work with have literally been on the front lines of this for over a year. They were raising the alarm before there was even the name of COVID-19. And so the challenges are immense. The dollars that are coming from the American Rescue Plan are absolutely critical. We need funding for the work that's being done right now. We certainly need more funding for how we're going to get through this and to the next phase, post-pandemic. But it's been a real challenge across the past year. So the way that the federal government has really engaged, especially last year, was pretty hands-off. It really said, here, states, here's the money, give us your plans. And then in each state, the state determines if, how much, when, what other strength might be attached, if local health departments will be included in either that planning or those funds. And again, everything's being done on really short timelines. What ends up happening is that there's a real varied response depending on what state you live in. So it's not even necessarily what's happening in Iowa, in a county in Iowa versus a county in Missouri. So what we end up having are kind of patchworks of different plans at different states, different levels of funding in different localities, and not really that clear national plan. This is where we're all going. We saw this a lot with the early vaccine rollout, where every state's prioritization and plan was a little bit different. But if all of us watch national news, we listen to fantastic national public radio, we hear what's going on in other places and want to understand how that applies to us and why it doesn't. And so that national level of planning has been certainly a challenge. And then obviously now with the vaccine deployment, the federal government is playing a key role in making sure those vaccines get sent out, but the localities and states seem to be working together to make sure they actually get in arms.
Yeah, and states seem to be in very different places in terms of that. I mean, presumably every state is getting a similar percentage of vaccine for their population, yet some states are way far ahead, and some states, including mine, are way far behind.
Yeah, I mean, and that's the varied nature. We really haven't had that national, like, this is how we're doing it. It's really been, each state, we have 57 plans when you add in the territories, right? And then local health departments, even in the majority of states where they aren't necessarily a function of state government, they're trying to work within whatever the feds are telling them to do and whatever the states are telling them to do, and then the reality on the ground of what's going on in their locality.
All right, well, I want to back up a little bit and ask each of you the same question, which is, what's the most important lesson that you have learned from this past year? And we'll go back in the same order. So Frederick, you start.
I think probably one of the most profound lessons that we've learned that really I think is going to influence the direction of health policy and public policy in the years to come is the interconnectedness of our health and our economic vitality. I think that there's been a real awakening to the notion that health, if we don't have a healthy population, we don't have our population's health protected, we cannot thrive as a country economically. I think that's a very powerful lesson. I think it has a lot to say about where we're headed in the next couple of years. We're excited at Families to think about the ways in which Congress and the administration can really activate to better protect and ensure that all Americans have access to health. And the other, some of the other key findings that we're about to release, the thing that's most interesting is after the pandemic, after everything we've lived through, we talked a little bit about this, the renewed understanding of the social determinants of health, the interconnectedness of our health, all those things, all those themes are coming out in the research we're doing. But the number one issue that American families are bringing forward, and one of their top 2 or 3 issues consistently, this is Republicans, Democrats, independents, rural, urban, it doesn't matter. There's a real consistency is they are very, very concerned about being able to afford healthcare. Right? So when you take that concern about affordability and you link it into the lesson of our economic vitality being closely tied into the ability of the American population to be healthy, it really puts a lot of pressure on the new Biden administration and Congress to take some really bold steps to address the affordability of healthcare fundamentally.
George, what's the single most important lesson that you've learned from this past year?
For me, I would say it's the value of information. Just to give you an example, within my health system, we felt pretty prepared for the pandemic. We did a lot of work to prepare our hospitals to receive patients with COVID. We optimized our supply chain of PPE to be able to move PPE from one hospital to the other so no one ran out. We worked on testing, capacity. We worked on clinical algorithms to triage patients from home to hospital to ICU or wherever. We stood up clinical trials across our health system. So we were enrolling patients to study the disease. And we did that all quite rapidly. We had good collaboration with our state health departments, and we had good collaboration with the CDC. If you think about the fact that the first patient diagnosed with COVID in the US was also treated with a novel experimental therapy against COVID, which is now the standard of care in the US. It's mind-boggling the resources that we had to deal with this disease. On the back end, there are still people that don't believe that COVID exists. In Idaho, for example, the health administrators from a local hospital were begging their council to make a mask mandate. And one of the council members said he didn't believe that COVID existed, that it was completely made up. And the result is obvious. If you do not believe in the same facts, no matter the resources you have, the technology you do, the right doctors, health systems, it's going to fail. And we have a large proportion of our population that simply believes in disinformation. They don't believe COVID exists. They don't believe masks work. They don't believe in vaccinations. And this makes what we do on the ground so much harder. And we are directly affected by it. For example, in Eastern Washington, one of our hospitals, Sacred Heart Hospital in Spokane, was being inundated by patients coming across the border from Idaho because they ran out of hospital beds. And this was true. I have many friends in the center part of the country, in Oklahoma, where they were shipping patients to Texas and Kansas, trying to find beds. and that is a direct result of disinformation that's occurring within our society. So the lesson that I think I've learned is that unless we're on the same page nationally to deal with the problems before us, we're going to fail. And that is in large part responsible for the outcomes we've seen in the US.
Adrienne, what's your biggest lesson?
Well, I definitely agree with what I've heard from the other panelists. I think, you know, one of the things we in public health kind of talk about, but I don't think we've really been able to wrap our heads around is, you know, public health and healthcare are sisters, but they are different. And what we saw in the beginning of the pandemic, especially when you have no treatments, when you have no vaccine, when you don't have enough hospital beds, the only thing we have are to fall back on our public health tools, which are pretty ancient in a lot of ways. But we as a nation don't value public health the same way we value healthcare. And so for every dollar we spend on health, 97 of those cents is going to healthcare, and 3 of those cents is going to public health. But that's all we had, and that's all we had for a while. And that's all we continue to focus on here, because that's how we preserve our healthcare resources. I think that has been incredibly important, you know, re-solidifying for those of us who are all like, public health is the best, but also to have the community understand better, you know, what are those health departments doing? They're not just doing restaurant inspections and telling you how many people are allowed at the public pool. There's a lot that's going on beneath the surface every day so that we don't have these types of headlines. And so having that connection between public health, healthcare, and then also, as was mentioned earlier, how public health impacts all facets of daily life. And when we don't have that, we really can't have a functioning society. Those pieces, I think, and I hope are things that we have learned and also will be using going forward.
I feel like public health is kind of a disadvantage because it's public. We have the private, you know, healthcare system that, you know, has ads and billboards and, you know, huge communication staffs. We know exactly what they do. We know all the modern miracles. We see the commercials on TV all the time. But
Yeah.
public health, people don't know what public health does, and they don't even know we have public health until there's a public health crisis. Is there some way to fix that?
Well, the whole point of public health is that you don't know what we've prevented. That's kind of the point. Like, oh, wow, today I didn't get measles again. That's great. You're welcome. But that's not something that people are thinking about day in and day out. So there is an invisibility crisis with public health, and that has been a significant challenge historically as we've tried to actually fund this work to continue to keep these problems down. I know it seems like years ago now, but it was just a few years ago we almost lost our measles elimination status in this country because we didn't have enough focus on all these different areas. We have to triage, and we had pockets of under-vaccination that allowed us to have these outbreaks. So public health is with us all the time. We don't talk about it a lot, and frankly, what we're finding now is as people learn about public health and know how important it is, there is a backlash. We see in some states bills being introduced to try and take away public health authority, trying to make this false dichotomy of open society versus public health, whereas all these public health tools and efforts are being done to keep us functioning as best we can through hopefully once in a lifetime crisis.
Frederick and George, I'd love for you to weigh in on sort of public health versus our medical care system.
Yeah, this is a huge point. And I think that this is something that I think has been lost over the past 20 or 30 years. So, you know, I've had patients where they have tuberculosis and they're refusing their treatment, and they're clearly a danger to society. And, you know, they get brought into the hospital, and the public health officer can get a court order to have that patient stay in the hospital and receive treatment. I don't think people understand that public health, they are officers like police officers. They're there to keep us safe. So for example, if someone runs around with a gun shooting it, a police officer will probably track them down and you know, put them in jail or somewhere safe. People that walk around with coronavirus infection, that aren't wearing masks, that aren't social distancing, are also putting the population at risk. And at some point, you know, public health has lost that authority to say, you know, what you're doing is wrong. You know, these measures, which have been known since antiquity, including in 1918 during the Spanish flu, work, and it keeps the public safe. And I think that's been lost. And I think that people believe that their right to freedom, we live in a free society, which is wonderful. I mean, we're all blessed to live in the U.S. with the freedoms that we have, but they're not unlimited, right? And there are rules that we should follow, and public health is a subset of those rules that work to keep us safe. And I think that is something that needs a lot more support. Those ideas that what they're doing is working to keep us all safe, and needs a lot more support from the federal government to ensure the rightful place amongst the rest of the, police officers, courts, and everybody else that also does the same thing to keep us all safe.
Frederick?
Yeah, Julia, I would make two observations about this. The first is, fundamentally going back to Dr. Diaz's earlier comments, the public health is a science, and it's rooted in understanding things like epidemiology or maternal child health, behavioral health. And at its core, particularly when we have crises, there's really important principles in a public health response. And those are things like let science guide our reactions, make sure that information is provided free of bias or politicalization. People have to trust that the information they're getting is accurate. Describe what you know and what you don't know. Keep people in a very centered, very direct form of communication. And fundamentally, I think what we've lived through as a country, I mean, it's important to say this out loud and say it over and over again. We have had 5 times more infection as a nation than we should have. 5 times more, not twice, but 5 times. We've had 4 times more grandmothers and grandfathers and moms and dads and brothers and sisters and friends and neighbors die in this country, 4 times more than we should have, right? And that's because we decided as a country, either tacitly or overtly, that we were going to fight the science, we were going to fight knowledge, and we were going to make this very political, right? And I think that the first principle here around our public health response is we've got to put the interests of the country first, and our reactions in these crises have to be rooted in science and knowledge and honest communication, right? That's the first thing. Second thing I would say is in a much bigger sense, what we know is of the 3.5 trillion, whatever the dollar amount is today that we spend on healthcare in this nation, just pennies are going to things like public health or social determinants. Our behavioral health resources are vastly under-resourced as well. Our social services, right? And as a result, what we do is we have very, very expensive, very costly, very high price specialty care. And we've really allowed all the other systems that we have to atrophy, right? And so one of the questions we have to really struggle with is if we do have a renewed understanding that health is foundational to us as a country thriving, being able to be an economic engine, being able to be a dominant force in the world economy, if we know that is true, right? How do we address this terrible disparity between the way in which we approach, say, for example, a useless knee surgery that's going to cost you tens of thousands of dollars versus the pennies it cost for the vaccination or the obesity prevention program or the asthma prevention program, right? We have to recalibrate those things. And I think that's the big question. I think it is not a foregone conclusion. I think it's most likely that's not going to happen. I think you and Adrian have hit on some of the reasons. Remember that public health is funded, for all the congressional staffers out there, it's a discretionary program. It's funded hand to mouth year over year, right? It's not funded through Social Security Act. It doesn't automatically get funded. And as long as that's the case, we know the systems in this country that are funded through discretionary spending, Indian Health Service, VA, and public health, are terribly underfunded. And on the other side of the equation, we see that the programs that are funded through entitlement or through Social Security Act, in those instances, the healthcare sector has just hammered away on price. They've created, terribly abusive pricing, 3-4 times every year. Prices are going up for no good reason, right? So we've ended up in this very lopsided environment, and we have to fight hard to recalibrate that.
So, Adrian, here's a question for you. One of the big issues that's hindered both officials and the public has been a lack of timely, trustworthy data. Have we made any progress over the past year, and what do we need to do going forward to make sure that data can be shared in a way that it will become more useful?
So this is absolutely huge. We have public health. Let me put it in perspective. Pre-COVID, we are getting research out of CDC saying like STD rates of 2 years ago. That's how long it can take for us to get some of our data and finalize it. Some of our fastest systems might give you reports like a month after, and that's seen as like real speedy. Public health has not had the investments in data and infrastructure the way that pretty much every other sector has had, and it shows. We have far too many. I'm going to make the very typical joke that all of us make. You know, we're keeping the fax machines in business, but for some people, it's really just like keeping pen and paper in business and data entry clerks in business, because that is what it can take. And that this is a problem up and down the stream. So we know that this is a problem. CDC systems don't talk to each other. We know that that is a challenge with state systems, and then local health department systems are also facing these challenges, and oftentimes, even in the information they put in, they can't get anything back down. And so having data and being able to use data are two different things. The virus has shown, again, because it puts this magnifying glass on everything, how problematic that is when every second of every day we need to have a firm finger on the pulse so we know where to go and how to address what the challenge is as they keep shifting. So there have been significant investments over the past year from Congress in data modernization. How that is actually going to play out, given the amount of need up and down the system, I think is still to be seen. We know that a lot of that needs to be used at CDC so their systems can talk to each other, but if that money doesn't reach down back into local health departments through state health departments, we're never actually going to have the information that we need. We've also seen a real challenge in data reporting. So let's say all of our systems were perfect, we still don't have people asking the questions and getting the answers to put in there so that we can actually figure out with a more clarity, you know, how our response is working. In the springtime, when we were looking at our testing data, and there's this huge question of, well, how are our testing, how is it rating based on vulnerable populations and minority communities? And when you look at it, so many of the forms just are blank. And so in regular public health times, you get a blank form, say for something like an HIV test, and you go and call them back and say, hey, you forgot to fill this out, what is it? You can't do that when you're processing thousands and thousands and thousands of pieces of data a day. So that's a huge challenge. Having the data is really important, and then being able to access it and implement it is also a second piece. One of the challenges we have at local health departments is there are data systems at the federal and state levels used together, but local health departments do not have access to those data systems, despite the fact that we think they do. That's a problem right now with vaccines. So local health departments don't necessarily know where the retail pharmacy program is within their boundaries. They don't necessarily know which community health centers have vaccine within their own boundaries because they don't have access to those data. These are challenges that we had during testing, we had during contact tracing, we continue to have during vaccine. And if we don't start thinking about this differently, we're going to continue to have the same blinders on that make this response even harder than it already is. A good example, though, that because I'm usually negative Nancy, is that when you do have data and you can act upon it, you can make changes. So in vaccine distribution, the city of Chicago, which is one of the few directly funded cities and gets their own vaccine allocation, so they can do this, noticed that they had a significant disparity in their in vaccinating people of color. They were then able to say, okay, so what populations, what neighborhoods, what housing blocks are we missing? Partner with community organizations there, work around some city challenges of can you use a school, can you not use a school, and come together, call out to people, go knock on their doors versus waiting for them to register and call you. And we're able to make significant impacts in improving the rates of vaccination. You need to have the data, first of all, to do that. You need to have the flexibility to then act on those data, and then you have to have the people to do it. And those are all things that are interconnected when we're thinking about this data challenge.
So I have a related question from the audience, and audience, please feel free to submit your questions, and I'll try to ask some of them. And then I'm going to ask the other two panelists to weigh in on the data issues. Here's a question. It says, I'm sure I'm not alone as a person who has entered personal information on several sites, including various Facebook vaccine hunter pages, hoping to find a vaccine for myself and family. As a health policy person, I'm beginning to wonder about privacy issues and what will happen with that personal data. What special protections for this data should we be thinking about, or is it already too late?
I feel like this could be another whole hour and change of conversation. HIPAA does apply for these issues. What I don't know is, what are the systems you're putting your data into? I'm sure that there are people trying to take advantage of this, as they do all things, trying to scam people, unfortunately. One of the challenges we had that leads to having all these different registration points and all of them not necessarily communicating and working together is, if you remember back, we had, as a nation, put billions of dollars into vaccine development, knowing that this is going to be what we need to get to in the future, and we will invest in the science. We had been asking Congress since the spring to also put some investments in vaccine deployment infrastructure so that we could build those systems in advance. Congress.
That would have been nice.
I worked there. We love you. Also, the money did not come until December 28th, which was weeks after vaccines were already being sent out the door. Then the ACIP had recommended what stages we were going to open up vaccination to different people, and that kind of got tossed up into the air while people were working on given plans, meaning more community members were able to access vaccines, which is a good thing, but those systems weren't necessarily built out yet. So we are building the plane while flying it, which is the story of this pandemic. And it's really difficult because, as I mentioned before, we don't have that centralized focus of where vaccines are coming through. So you have these different places to register. It's not great. We're all working through it together. The hope is, every day we learn from it and we can actually put it together to have something a little bit better. But HIPAA does apply, and there are probably lots of other conversations to have around that as well.
And Julie,
George, I'm sure you have feelings about data and the lack thereof, or the inability to access it thereof. Oh, you're on mute.
Yeah, this is a big issue in the US. To give you an example, in the UK, they can generate clinical trials and enroll thousands of patients over a few month period and generate, really robust results. If you look at COVID studies, you can look at the studies for steroids and other treatments. They're enrolling thousands of patients across their health system rapidly. Our clinical trials in the US are enrolling hundreds with a lot of effort. And that's really a result of our disparate EMRs that we have in the US. So the current model for a vendor for an EMR, they have an out-of-the-box product they sell to their health system. In my case, we have 51 hospitals. What they're selling us doesn't meet our needs. So we hire a lot of analysts and doctors to customize it in a way that we can make it usable for whatever data that we need. When there are requirements for testing, someone wants to know how long this person had symptoms, or were they, a healthcare worker that we're testing. We're building those rules into our EMR on the local level or system level with a lot of work. But that doesn't mean that another health system or hospital is doing it the same way we are, right? And so you're getting disparate data sets that are very difficult to compare. Where the requests for data should be going to are the vendors of these EMRs. Because, for example, in the US, there's two very large vendors that account for probably 80% of the health records across the US. The burden of generating the data is to health systems and hospitals, and not the vendors of the electronic medical record. This is something that could be developed centrally, within the vendor's office, and pushed to every single hospital that they sell the EMR to. And you would be able to generate and report on standardized data discretely across millions of patients across numerous states with much more ease. And I think that burden of data acquisition needs to move from the local health system hospital level to the people that are actually designing these EMRs. because we are wasting a huge amount of resources trying to do this data generation from hospital to hospital when the vendors are able to do this on their own for their entire population of folks that they're selling these tools to. And that's the difference between us and the UK. They can generate their data very quickly with thousands of patients because they have the platform that's unified in a way that they can generate this data, validate it, and report it quickly. For us in the US, when we're starting a clinical trial, we can get a study up in amongst 5-10 hospitals over a couple of months, and we can generate data on a few hundred patients. That's simply not fast enough to make a difference in the care of these patients. We have to be able to leverage the size of our country and our EMRs to be able to generate the data necessary to improve the lives of patients. The data's there, it's just sitting there, but it can't be mined, and it's not standardized. I think that's...
Frederick, go ahead. From an advocacy point of view, what does it mean to sort of not have access to literally know what's going on?
Yeah, Julian, this is such an important issue. It's one we're very active on at Families USA, and I'm sure for the staff out there, the congressional staff who are listening, it's the issue that you can bring to your boss and their eyes will just glaze over and they will just doze off because it sounds so boring, but fundamentally it's incredibly important. And just to kind of tie these things together, I think agents describing the very complex and difficult data environment in which public health exists. There's a much larger data ecosystem that we're talking about, which is really all of the different healthcare systems that are running, including physical health and medical care, as Dr. Diaz is describing, but then we have behavioral health and social services and on, right? We've done a bunch of looking into this. I've done a bunch of research into it. I've done it in previous lives when I worked with the governors, when I worked at advisory board. Here's what we know for sure, and I want to say this really clearly. First and foremost, it's really important to understand in an environment of fee-for-service economics where health systems, corporate physician groups, insurers are being held responsible for units of care. I need to get my appendix out. I need to get my hip replaced, whatever it might be, right? It is in no one's interest at all to be sharing data. In fact, it's against their business interests to share data, right? A hospital does not have any financial incentives, and it doesn't make sense for them to let other hospitals have access to their patient records, what they're doing with patients, et cetera. That's the first thing to say. It's really important to say is we did qualitative and quantitative research with hospital executives, and they all told us this, right? The second thing is, remember that fundamentally, these data, to me, they might be the most exciting, disruptive innovation that we could achieve as a country in healthcare. If we can allow these data to flow so that we can actually analyze two things, cost versus outcomes and quality. And we can actually see where is value occurring in our system, which hospitals are getting it right, which physicians are keeping their patients healthy, and then when they get sick, getting them better quickly and most effectively, right? When we can actually know the answer to those questions, we can start holding our system accountable for their gross inefficiencies, right? But right now, it is against the interests of the healthcare sector, and every step of the way. We just went through this at the end of the year with the end of the year package. We got the state all payer claims database enacted. It's happening now. Every single provider group that we worked with, that we heard from, was against this. They were against this. And the last thing I wanted to say was also understand that from the insurer perspective, insurers have most of the claims data out there, right? And for insurers, there's an enormous economic opportunity for them to quantize that, to say, if you want access to that little, to find out what that person's doing, pay us a penny, right? And then you can make a lot of money. And so we also have to, there's a couple of things we need to settle as a country. The first is our data are our data. When I go to a doctor, no one owns that data. They can use it, but it should be in my service and to make me healthier, not to make a penny, for the insurers or make a penny for the vendors. The second thing to say is we have got to establish interoperability standards to say whatever data system this is, if it's public health, behavioral health, social services, medical care, whatever it is, here are the basic contours of an interoperable system that everybody has to meet, and then allow people to innovate with those standards. And I think the best analogy here is global positioning satellites, right? Back, I think it was in the 50s, the military finally allowed GPS satellites to be used for commercial purposes. That's when it all started very slowly to evolve. Think of all of the innovations that we have today, from our iPhones to Google to Uber to goes. I mean, it is hard to understand the way in which access to GPS has changed our lives. That's what interoperability standards are for us. If we can create a level playing field and say, here's what you have to be able to plug in and communicate this way, think about the incredible innovations that could happen in healthcare in our country. But what's stopping right now is that the business interests of healthcare don't want that to happen. So we need policymakers to step up and say, nope, we're going to create this level playing field, create interoperable standards, and then let's go innovate. Let's go find the ways that we can save people's health, get them healthy, make things more efficient.
I've been hearing about this since the Bush administration, possibly the first Bush administration, but definitely the second Bush administration.
That's right, Julie, and that's a great point to make. It's utterly bipartisan. You know, the Bush administration was the first administration that really started to innovate with this, right? It should be utterly bipartisan.
So, well, I don't want to spend the whole rest of this time on data, although it is super important. George, here's one for you. COVID-19 has shined a very bright light on just how fragile our medical care system is. What's been done to make it more resilient, and will some of these lessons, push forward into the future?
Yeah, I think that's a really good question, a difficult answer. The hospitals that are health systems that are the smallest are the ones that generally struggle the most. They're the ones that don't have access to additional resources internally. And even within my health system, for example, which is large, we've got 50 hospitals on the West Coast. We had issues with supply chain. We were, in order to have enough PPE, we were collaborating with businesses locally to change from being producers of furniture to be producers of PPE. So, this was on the ground innovation to improve our supply chain. We ran out of swabs, for COVID testing at sites. And so we were having to do alternate methods or, other things to try to get people tested correctly. And so even a large health system that's well funded on the West Coast still has issues with supply chain. This is a larger issue than the largest health systems in the country. And these supply chain issues have to be addressed at the national level. When COVID was first being found on the West Coast, the University of Washington took it upon themselves to modify their lab to be able to do high throughput COVID testing. And at least locally for me, that saved us. We were able to ship our samples to the University of Washington rather than to use the state of Washington Department of Health lab. And that helped us enroll patients, that helped us diagnose them and treat them correctly. We have so many labs in the Puget Sound that do genetic testing or DNA-based testing that it wouldn't have been hard to convert many of those labs from what they were doing in basic research to COVID testing labs for a short period of time to allow us to really raise our ability to get the throughput necessary on a at least multi-state level scale. But it didn't happen. And that sort of delay in testing really harmed us across the West Coast. And I think that has to occur at the federal level. There has to be a federal response to supply chain, whether it be PPE, whether it be testing, or whatever it is, because even a large health system can't manage this on their own, right? I mean, there's only so much PPE we can create on our own, for example, and those supply chains and other critical resources have to be secured very early on by the federal government, and it didn't occur, and it made our jobs much, much harder. So I would say that we're extremely vulnerable as a nation to another pandemic. I don't think we're at a point where if COVID-21 came, that we would be in a great position to manage that either, right? These issues haven't been solved even now. So, I think this whole how we address the next pandemic is on the federal government. It can't be on the state. It cannot be on the health system or the hospital. We will be overrun.
Either of you, Frederick, you want to address this one, or should we move on? Okay. I have another question from the audience. What do we say to people who believe the conspiracy theories? They are still people. They are our neighbors. Sometimes they are our relatives. How should public health and science engage? George, you sort of touched on this in the idea that there are a lot of people out there who don't believe it. But how do we sort of regain their trust that scientists and medical professionals actually have more information than the general public?
We have to have unified messaging across our country. It has to be from your doctor. It has to be from your public health official. It has to be from your governor. It has to be from your president. It has to be everybody in the US on the same page to deal with this. Imagine if we went to World War II with a divided country. We wouldn't probably have succeeded. You saw what happened with the outcomes with when the US is divided on opinion in places like Vietnam. And so anytime our country is divided, we're not going to do very well. And this pandemic showed the same thing, that if we're divided in our opinion, or divided on the basic facts that we believe, we're not going to do well. And it's sad because we have amazing resources, innovation. We have companies that are generating new therapies. We've got the best vaccines in the world being made here. And yet we still have this kind of outcome, and it's directly related to people's beliefs. There are people that believe in false information, and we have to have everyone saying the same thing that's based on science and truth. And that's where our problem is.
Adrienne?
Everything that Dr. Diaz said, I think one of the challenges, what we haven't had over the course of the year necessarily, was saying what we know and what we don't know. There was a lot of, we'll get to the summer, we'll get here, very short-term thinking. When Dr. Messonnier, a little bit over a year ago now, said, hey guys, things are going to change and this is how they're going to change, she was yanked off the airwaves. She was not permitted to do those media engagements again. That's a huge challenge. While it's clear that we need to have the same consistent messaging from the federal level, from the state level, from the local level, it's also important that we actually invest in this effort. You can't build trust in 20 minutes. And so when you have a system that we expect is only going to pop up when you need it, but then just gonna kind of go hibernate in the meantime, you're not building those relationships and doing that outreach that's necessary so that you can then have tough conversations. We know that there's been a lot of research done around especially vaccine confidence and how you work with that, and a lot of it is that what your provider recommends. Do you see anyone else in your family who has gotten vaccinated? What are those close connections mean to you? There are people for whom sometimes you're just saying, whether or not you believe it, can you just act this way to let's just so that we can all kind of move through it. I think things are getting better. There's more of that, more consistent messaging, more clarity. But it is a challenge. It will continue to be a challenge. And frankly, public health tends to not want to get in the fray sometimes. But the fray in social media is where a lot of this, hibernates and lives and then pops up again. And so sometimes we need to be thinking not just as scientists and as public health people, but as just communicators. And how do we market that everyone all of a sudden thinks that jeans that go up to your armpits are again in style? I don't know how you market that, but apparently it's a thing. And if you can start thinking like that, you're probably going to get your messages through a little bit better than being well, in science, we never say this is 100%. So it seems to be that we will have an increased ability of not getting really, really, really sick if you please and thank you go get a vaccine. There has to be a happy medium between these two.
Frederick.
That was, Adrienne, just props to you for being able to bring high-waisted jeans in this conversation. It's a reference that most of us
very opposed.
Yeah.
Those of us of a certain age definitely will remember that.
For sure. So some really important things to say here. I think we actually we went to the field to talk about messaging in the middle of the pandemic with one of the leading kind of strategic message gurus out there, Dr. Drew Weston. We have a messaging guide on this that's available on our website. We really encourage folks to reach out if you'd like to take a look at it. But we learned a lot of really important things. There's two things I wanted to say to this. It's a very important set of questions. The first one is this. I think we have to understand, for everyone out there, that we have, as a people and as a world, undergone a very significant change in technology. And that's really rooted in social media and the way that social media works. And we know, and we're hearing members of Congress start to talk about this, we know that we've created very powerful algorithms that are built on machine learning that are aimed at us, and their entire purpose is to activate our reptilian brains and get us to click and look at things, right? That is happening. And that's happening to conservatives, and it's happening to progressives. This is not a one side or other, right? In that environment where we are so highly activated, it creates a terrible opportunity for, as Dr. Diaz and Adrian have said, for the very foundational facts to be called into question, right? We lose our anchoring in facts. And so I think first and foremost, there's a fundamental policy question for Congress to really think about: how do we operate a democracy, one of the oldest and most mature democracies, in the environment of this social media revolution? Because what's currently happening isn't allowing us to have meaningful public policy debates that can move us forward, right? I just want to get that out there. I think it's going to be one of the biggest issues in the next decade for us to struggle with as a country. And there's a lot to think about there. There's a lot of ways that we can create guardrails and make sure that we can operate a vibrant democracy in that environment. But beneath that, what I wanted to say was, it's also time for us, all of us. We all come from different perspectives, different political ideologies, different life experiences, right? To stop arguing about what our beliefs are, right? And just really speak from what we're trying to achieve. And this is what our messaging research shows time and time again. So I think progressives need to stop talking to the world as if everyone was progressive. It's exhausting. They're not. And therefore, when you say to people healthcare is a right, there's a lot of people who don't believe healthcare is a right. Why are we arguing about whether or not healthcare is a right? It's a waste of time. What we do know, however, is, and we went into the field and we message tested this, right? Across the political spectrum, Republicans, conservatives, and everyone in between, almost all of them agree, when a family in this country gets sick and needs to see a doctor, they should be able to see a doctor and they shouldn't go bankrupt. Most Americans, almost all of them, believe that. So let's start with that. How do we get there, right? Second thing is, most people agree that right now the healthcare system in this country is working too much for the benefit of health insurers and hospitals and pharmaceutical companies, and not enough for all of us as families, right? Let's start there and let's build from there. And so I hope coming out of this, that the response to the incredible division and the demagoguery that we've seen the last few years, instead of that, what we see is, let's start talking to each other about the things that we can agree on and move forward. And if anyone out there is interested in this work, we're working right now on getting it out there. But it's a really beautiful messaging guide that kind of lays out how we can build these messages that bring us together, unite us to achieve these really fundamental improvements that we all need.
All right, well, on that hopeful note, that is all the time that we have. Thank you all for your insights on this really important topic. Please, audience out there, take the time to complete the brief evaluation survey that you'll receive immediately after the broadcast ends, as well as via email later today. A recording of this webinar and additional materials are available on the Alliance's website. Frederick, George, Adrian, thank you for joining us. And that's it.
It was a joy to be here.
Thank you.
Thanks all.